I'd like to first thank the organizers for this meeting. I'm really grateful to be here with all of you and tell you a little bit about the work we do at the University of Utah. The first thing I'll tell you is that I unfortunately have a lot of acronyms in my presentation, and so I'll try to work through those as we go through. And so our name is mixed in with some of those acronyms. So the first I'll tell you is that the ETSP, or Epilepsy Therapy Screening Program, is a contract-based work out of the NIH and the NINDS, National Institutes of Neurological Diseases and Stroke, that many of you may be familiar with. The ETSP is part of the epilepsy division, and they have run a contract for competitive renewal about every 5 years for many years, and I'll talk about that. So at the University of Utah, we've been awarded that contract, and so that we refer to ourselves as the contract site, which is to say that we perform all of the testing that is done by the ETSP. The second thing I'll tell you about that is that we work with animal models, mouse and rat models of seizures and epilepsy, and so we will be talking about that today just a little bit. These are my disclosures. None of them have any bearing on the discussion for today. Our first objective is to understand some of the capabilities for testing that we have with the ETSP, and also understand what the overall approach is to screening compounds, particularly for Dravet syndrome. And we use a hyperthermia-induced seizure model. We also can screen for spontaneous seizures in our mouse model, and so I'll talk about that. Okay. So I'll give a brief overview of the ETSP, where I'll be stepping away just briefly from Dravet syndrome to speak about epilepsy in general and rodent models of epilepsy. Then I'll tell you about our mouse model. Our model is one of several that are available in the field today. We have instituted this model, but I would like to point out that there are other mouse models that you may hear about. There are some similarities and differences, but we use this model in particular for our drug screening purposes. We also, as I mentioned, use a hyperthermia-induced screening paradigm where we induce hyperthermia, and I'll explain that. And then we use that paradigm to screen drugs alone, monotherapy, or drugs in combination as a polytherapy approach. And then finally, I'll talk about our use of spontaneous seizure recordings using video EEG. So first I'll tell you about the ETSP in general. It was formerly known as the ASP, or Anticonvulsant Screening Program. And the ASP began in the mid-1970s. So what had happened in the field of epilepsy in general is while we had a few anti-seizure drugs such as phenytoin and phenobarbital and carbamazepine that had been approved for epilepsy, what was observed was that there was some stagnation in the development of new anti-seizure drugs, and very few drugs had come on the market. And so that spurred a public-private partnership and a development of a screening program funded by the NIH, wherein participants, which is to say drug companies or academic labs, or in some cases even government entities, could approach the NIH with their compound, with their therapy, and the NIH would fund the screening work in rodent models for that compound. And what we saw over the next several decades was that the ASP, or the ETSP as it's now known, contributed to the development of many of the second, third, and now fourth generation anti-seizure drugs that are currently available, and those are shown in red arrows. Okay? So in some cases, the work that was performed was some of the principal early preclinical pharmacology that helped to support an IND and application for some compounds. And in other cases, the work that we performed was helpful in learning more about the mechanism of action and the potential utility of some of those compounds. Okay. So the University of Utah has held this contract with the ETSP since 1975. And for the last 15 years or so at least, it's been under competitive renewal every 5 years, and we just renewed that starting earlier this year for the next 5 years. Our current principal investigator is Karen Wilcox. Before that, Steve White was our PI. And we have a long history of leaders in the field serving as principal investigators and directors of our program. Our goals, the first thing I'll tell you is that they have evolved over time. Currently, we're focused on two main areas. One is the development of new anti-seizure drugs, particularly those that are important for drug-resistant epilepsy. As many of you are aware, there's about a third of all patients that don't experience seizure freedom, or that experience a number of side effects with their current anti-seizure medications. And so one of our goals is to help to develop new drugs for pharmacoresistant epilepsy. The other area that we're focused on is the development of compounds that may prevent or modify the progression of diseases, of epilepsy, excuse me. As I mentioned before, for a participant that approaches the ETSP, the testing performed at our site is done free of charge, which is to say it's taxpayer funded. It does require that anyone that brings their compound or their therapy to the ETSP meets their criteria, their benchmarks, to be included as a participant in the program. We at the contract site are blinded to who the participant is, who the supplier is, and also to the nature of the compound. So in our lab, what I see is a vial with a 6-digit code on it, and that comes with instructions on how the drug should be formulated and tested, but we don't know anything beyond that until often years later when it's disclosed at meetings like this or pipeline conferences where we hear, oh, this drug was tested at the University of Utah, and we can say, that's great. We didn't know at the time. But that's really gratifying to see that we continue to contribute to the work of epilepsy drug development. Our goal is to help in providing early preclinical data that can inform later late-stage clinical and even clinical decision-making about dose range, efficacy, tolerability, okay? And so it's not uncommon that some of our data generated becomes part of IND applications, other regulatory filings, work to help gain further funding for some compounds. And so we provide that data in the form of various reports and data summaries as best we can to try to facilitate that work. What we'll talk about today a little bit also is that, and I alluded to this before, is that our program has evolved from the early stages of having just 2 or 3 seizure models to a number of different models and a number of different modes of testing that I'll highlight here in just a second. And most recently, we have included a model of Dravet syndrome that we are very pleased to present and to have as a potential tool in the development of new drugs for epilepsy. And the last I'll mention here is our colleague, Dr. Brian Klein at NINDS. If you are interested or know of anyone that has a potential platform, a program, drugs of interest, please approach them. We'd like to test as many agents as we can in our models to try to facilitate new drug discovery. Okay, so I'm going to continue to step away from Dravet syndrome for just a minute, but then I'll rejoin that in just a little bit further down the road. The first that I'll tell you is that, as I mentioned, we have evolved the program in recent years beyond just a few models to a really robust and fairly comprehensive cohort of tests that we can offer. On the left of this diagram is what we refer to as the identification stage of testing. The goal of the identification stage is to learn a little bit more about a drug in terms of its dose range, its tolerability, and its time course of action. And we do that in a couple of different ways before the compound advances to differentiation, where we try to get a better understanding of how the compound might work in more etiologically relevant seizure models. So on the far left, when I say acute seizure models at the left top of this diagram, what I mean is testing in a previously drug-naive and seizure-naive animal. So those tests are very well established, the 6 Hertz electrical seizure assay and the maximal electroshock seizure assay. So we use those models, again, across a couple of different time points and doses to try to understand a little bit more about how the drug might be working. From there, we will also look at tolerability. Our tolerability assays are primarily centered around motor impairment, so we use the mouse rotarod test, minimal motor impairment locomotor assays. I won't have too much time to go into those, but let me know if you have any questions. But again, motor impairment is where most of our behavioral tolerability assays are focused. In recent years, we've also introduced what's referred to as an Irwin test or a functional observation battery. And that's a test that's commonly used in middle to late stage preclinical drug development that gives a little bit more of a deeper look, if you will, at tolerability profiles. So we're happy to provide that to program participants now. We also will go into what I'll refer to as chronic models, which is to say animals that have had seizures before. And we use the corneal kindling model and also a kainate model. And there's a couple of different ways that we can use those assays. If you're unfamiliar with the term kindling, because I'll use it a few times, kindling is where a very small stimulation is provided, but it's provided repeatedly, and where once that initial stimulation was subconvulsive, eventually after repeated stimulation, the animals will have convulsive seizures, and so we consider them kindled at that point. So again, that's another assay that we use in mice and also in rats. For compounds that we believe may have a good mechanism of action, but for whatever reason are not getting into the brain, from what we can tell, we can take brain tissue from animals that have had seizures following canic acid and take brain tissue out that displays spontaneous bursting behavior, and then we can bathe the drug across that brain tissue and ask the question whether that spontaneous hyperexcitability, that spontaneous activity has been diminished. So on the identification phase, this gives us an idea about how and when a compound may be working. And then for some compounds that have proven themselves, if you will, sufficiently, we can advance to the differentiation phase. And so in the differentiation phase, these are more etiologically relevant seizure models where we can ask questions like, if we give this drug repeatedly, does it reduce spontaneous seizures? Does it reduce seizure burden? And so we use a couple of kainate models in mouse and rat. We use the intrahippocampal kainate model through a subcontract with Synapcell, where we can administer the drug and ask if that hyperexcitability behavior is decreased. We can also use the intraamygdala kainate model and administer the drug subchronically, which is to say over days or even a few weeks, and ask whether we see a reduction after drug treatment in the number of seizures, the frequency of seizures, or the overall seizure burden. We have a kindling model in rat as well that we use, and during the kindling process we can administer lamotrigine, and what that does is if lamotrigine is administered during the kindling process, we see that animals become drug resistant to lamotrigine and other agents. And so this helps us get at that potential question of, are there drugs that we can screen that are effective where other drugs have failed? We also use a post-kainate rat model. And this is where compounds have really been thoroughly tested in a number of different models. And we have a good understanding of dose range and tolerability. And then we can administer this drug into rats and ask whether spontaneous seizures are reduced. So that's the overall paradigm that we have for screening drugs, particularly for pharmacoresistant epilepsy. We've also developed a few other models that help us where there are agents that maybe have unique mechanisms of action or a particular preclinical profile or an overall preclinical direction. One of those may be inflammation or treatment of viral-related epilepsies, and we use the TMEV or Tyler's murine encephalomyelitis virus model. which is primarily a handling-induced seizure model that's associated with a great deal of inflammation, and so we use that model to screen. We can also screen for status epilepticus. We use the lithium pilocarpine model. And finally, we have instituted a model of Dravet syndrome. So what I'll tell you is that as we are screening compounds for Dravet syndrome, we don't always expect that those compounds would have acted like most or other anti-seizure drugs would have. And so sometimes what I've shown you here in the rest of this diagram, that information can be used as we approach our Dravet model, meaning that we might know an idea about dose range, tolerability, and time point, but that's not always the case. And it may come as no surprise to you that some of the mechanisms of action for treatment against seizures and Dravet syndrome are different than traditional anti-seizure drugs. When we can, we like to test a new agent in some of these other models so we have an idea about how it might be working. But we're also finding that some of the agents that we test are pretty unique, and so we have to do our best guesswork in terms of what doses to use. So as I mentioned, we've instituted this Dravet model, and I'll explain a little bit more about that in the coming slides. So first, as I mentioned, there are a number of different mouse models for Dravet syndrome that are available. And if you attended yesterday, you also heard about some in vitro models and also some a zebrafish model that you'll hear more about. And so I'm going to focus on the mouse model, but do keep in mind that there are a number of different ways that we could potentially screen for drugs that could work against Dravet syndrome. So this is the NAV 1.1 sodium channel, which is the product of the SCN1A gene. The mutation in the mouse model that we use is shown on the far right in blue writing, the A1783V variant. Now, what you'll hear about for some of the other models is a haploinsufficiency, which is to say a reduction in the amount of protein that's made. Okay, for this protein product from this mutation, the protein that's made is functional. Okay, so this is not a haploinsufficiency model, it's a different type of model. But as I'll explain to you, it does have some of the key characteristics of Dravet syndrome. Okay. So what we see in terms of the channel characteristics for this model is as shown in red. If we have this ion channel NAV 1.1 expressed in cells, in red is the mutant variant and in black is the wild type variant. We see that the kinetics, or the way that the channel works, is a little bit different. And so on the left side of the graph, you'll see that on the inactivation side for the channel, as voltages are increased, there is more of a stabilization of the inactivation kinetics, whereas on the right side, we see a stabilization of the closing of the channel. And so that leads us to believe that in a similar way to haploinsufficiency, we do have a lower overall effectiveness of the ion channel. But again, as I mentioned, this is a different type of mutation. We have been less focused on the electrophysiology and the function of this channel and more focused on the behavioral characteristics of this mouse. But I did want to let you know, for those that may be interested, how we think this channel might be working and why it's producing these characteristics. One of the first things that we noticed when we bred these mice is that the mice that are homozygous for this mutation are not viable, and so we don't use those animals. Our breeding scheme produces about 50% wild type and 50% heterozygous mice. And so what we noticed in our hets is that they have a high mortality rate, which is consistent with other mouse models of Dravet syndrome. We lose about half the animals, and the majority of that loss of animals comes between postnatal days 15 to 30. And for those of you that are familiar with mouse lifespans, that generally correlates with childhood. And so we feel that this is a reasonable model for what may be happening in human patients. The other thing that we noticed is that the mortality rate is higher in females. We don't really understand why this may be the case, but we are keeping an eye on it. So now I'm going to transition and talk to you about our hyperthermia-induced seizure model. What I'll tell you is that this is an approach that's used by a number of different labs, and so we adapted this from our colleague Jennifer Carney, and there are others that use this approach as well. So we use a temperature controlling unit and a heat lamp that essentially delivers an elevated temperature wherein the mouse's temperature is monitored for several minutes. And then their overall body temperature increases on the order of 1 to 2 degrees Celsius per minute until the animal has a seizure. All of our hets will have a seizure, a hyperthermia-induced seizure, and none of our wild types. And so that lends itself to screening. And so what we'll do is administer a drug, say 30 minutes or an hour or 2 hours, before administering this hyperthermia stimulus. And then the way that we perform the test is we take a cohort of 10 to 12 animals and inject them all with the same dose of the drug at the same time point, and then observe what hyperthermia does, and then make note the temperature at which the animals will have a seizure. And so that produces these temperature curves that are shown in the right. In the middle, with sort of the orange line, you can see that if an animal is treated with vehicle, we don't see any difference or any major shift between what a vehicle treatment does and what a wild type, or excuse me, a non-treated heterozygous animal will have in terms of what temperature at which they will have seizures. And so for a drug that's not effective will tend to look like that. They'll all have seizures averaging right around 38 or 39 degrees Celsius. On the upper right, in red, you'll see a drug like clobazam, and I'll show you an example of that in just a minute. And so what happens there to animals that are treated with clobazam, they still have seizures for the most part, but they have seizures at higher temperatures, and that's why that curve is shifted to the right. Conversely, and as it may come as no surprise to this audience, is that when we use sodium channel blockers in these animals, like carbamazepine, the curve is shifted to the left, which is to say that the temperatures at which seizures occur are much lower. Okay? And so we've used this as an approach to screen a number of different drugs, and I'll talk about that in just a minute. So one of the first things that we did is we used these prototype drugs, clobazam and carbamazepine. So clobazam is shown in blue. And what you can see there is at a dose of 10 milligram per kilogram, this is a single dose, we see that some animals don't have seizures by the time that we reach our cutoff, and our cutoff temperature is 42.5 degrees. When the animal reaches that temperature, if they haven't had a seizure, the test stops. So in some cases, we're able to protect against seizures. But for the most part, the average temperature at which animals will have seizures is shifted to the right. Okay? And then on the other part of that graph where we see carbamazepine, you can see the temperature is shifted to the left, which is to say they have seizures at lower temperatures. At the top of this graph, week 1 refers to the first week after weaning, and so these animals are roughly postnatal day 20 to 30. So we wanted to ask the question, if we wanted to use these animals to screen several drugs, could we test at a couple of different time points after weaning? So could we test at P20, P30, P40, and so on? And so we repeated this test in the same cohort of animals at several subsequent weeks, and what we saw is that the overall effects persist. Clobazam is protective, carbamazepine exacerbates seizures, and that continues at week 2 and then week 3 and week 4. So the reason why we wanted to do this is we wanted to be able to convince ourselves that if we wanted to test, say, 4 drugs or 4 doses of one drug, could we test on subsequent weeks? And so this gave us a lot of confidence that we could do that. So a few years ago, at the Dravet Research Roundtable in Baltimore, I believe it was, Helen Cross gave a presentation that really caught our attention. And what was presented was the overall paradigm for how drugs or multiple drugs might be administered to patients with Dravet syndrome. And so the reason why this caught our attention is we were observing that our model was generally pharmacoresistant, which we feel is a good thing because many patients with Dravet syndrome don't respond very well to drugs. We looked at this, though, and said, here's an opportunity for us to use a clinically relevant polytherapy approach. So the first-line therapy for many patients with Dravet syndrome is valproic acid or clobazam or both. And then if patients are unresponsive, another drug like stiripentol may be added on. And then you can see here a number of different agents that are available. So we took this approach and said, can we administer valproic acid and clobazam as a base and then add a third drug on? And then we can ask the question, okay, trying to model what's happening in the clinic, can we use this polytherapy approach and say, let's envision that our patients, our mice, are already on this therapy. Can we add another therapy on? And so we performed that initially with stiripentol. And so on the left, we took a minimally effective or non-effective combination of valproic acid, 75 milligrams per kilogram, and clobazam at 5 milligrams per kilogram. So clobazam by itself at this dose doesn't work. What I showed you before was 10 milligram per kilogram of clobazam that did work, but at this dose it's not effective. Valproic acid also at this dose is not effective, and together they're not effective. However, when we add stiripentol, which by itself at 100 milligrams per kilogram is not effective, we do see a significant shift or protection increase in the hypothermia-induced seizure threshold for stiripentol. And so we use this as a benchmark to be able to say, do we have agents that we can add on as a third drug to valproic acid and clobazam that can produce similar efficacy as stiripentol does? And so we refer to that as our polytherapy approach. And so a drug that enters this program might be tested as a monotherapy, and then we can use this polytherapy screening approach to ask the question if it works in this paradigm. So in the monotherapy paradigm, we've published some of these. That paper is Pernizzi et al. That came out last year. And we're testing new drugs as well, and they'll be coming out in a forthcoming publication. So thus far, we've tested 16 to 20 drugs, and we've seen that a few work. So clobazam, as I mentioned, will reduce seizures. Tiagabine, interestingly enough, also works, and levetiracetam. We've also seen that, as I mentioned before, carbamazepine makes seizures worse, and so does lamotrigine when it's given subchronically. In the polytherapy screening program, we're still working on testing a number of different agents, but we've tested several and with several more to come. And we see, as I mentioned, stiripentol works and also cannabidiol in this paradigm. And so we're really excited about this opportunity to be able to take a couple of different looks at new drugs that come into our program. And as I mentioned before, we'll also have a paper coming on this, hopefully later this year, first part of next year, that will have more information about this. Okay, so the next thing I'm going to show you is a spontaneous seizure. So be advised, we'll be looking at a seizure in a mouse, for those of you that haven't seen that before. I'm wondering, I don't know at the back if you can hit the play button or not. Thank you very much. So what we can see here is this mouse is tethered. It has an EEG electrode implant, and it's connected by a cable and a rotating commutator at the top of the cage. So you can see the animal is starting to rear up, show forelimb clonus, and it'll eventually fall over. And the EEG trace above shows us a fairly robust seizure. And so the way that we observe seizures in these animals is we screen through the EEG and look for what appears to be a seizure. And then we'll go to the video that's taken in tandem and ask the question of whether that was a behavioral seizure or not that we can quantify. So for mice with this mutation, again, heterozygous, they'll generally all have seizures at varying frequencies. You can see at the end this was a relatively severe seizure in this animal, where at the end of its seizure behavior, it began to sort of jump around and show wild running type behavior. And that's relatively common. And then also afterward, you can see this period of EEG suppression. So we use this approach in animals to be able to observe them for long periods of time, often weeks, And then we could administer a drug in various ways. We could administer a drug in food, by repeated injection, even by subcutaneous pump. And we can ask the question, do we see a reduction in the number of seizures, and in some cases, the overall seizure burden? And so this lends itself to screening. However, what I'll tell you is that the hyperthermia-induced paradigm that I showed you before, we can take a group of animals, inject them, and then ask the question, did they have a seizure? What temperature was their seizure at? And that's relatively quick. With video EEG, implanting the animals, making sure they recover well from surgery, observing to see what their seizure frequency is, and then administering the drug and looking at seizures, as you might imagine, is a little bit more work. And so we have an army of EEG reviewers in our lab that are watching mouse EEG, mouse video, and helping us to count and quantify these seizures. So we love to be able to perform these tests to try to identify new compounds. However, it usually requires that a compound has demonstrated a reasonable amount of efficacy, or that we have some confidence in its tolerability so that it can be administered several times over several days. So we noticed relatively classic EEG type parameters with these seizures. They looked like other seizures that we had seen before in other models. One thing I will point out to you, though, is that we noticed that the interictal spiking behavior seemed to increase ahead of when we would see a seizure. Now, we haven't been able to use this in any paradigm yet, meaning we haven't been able to use predictive algorithms, for example, to try to stop seizures ahead of time. However, it does lend itself to that potential approach. So we're very excited to see this biomarker of seizure activity, of interictal spiking. And so we hope to be able to capitalize on that in the future. Beyond that, we also noticed that most seizures seem to occur during the dark phase, which for mice is when they're most active. And so it's our nighttime, but they're most active at night. And we see that they have more seizures at night. We've screened a couple of different drugs in this paradigm. First, carbamazepine. You can see that the animals have, on average, a seizure once every day, once every 2 days. And carbamazepine in food pellets increases that 4 to 5-fold. And then we looked at clobazam, and we administered it intraperitoneal by injection, and we also administered it in food and did sort of several different doses. And we saw that it really didn't decrease the frequency of seizures, at least in this paradigm. And what that tells us is, again, that these seizures are relatively pharmacoresistant. Now, from our perspective, that's not a bad thing. We are interested in trying to find compounds that work where others may have failed. Having said that, it also says that it may be a relatively high bar. We continue to use this model, and we are going to test additional therapies, potential drugs. But again, we sort of want to get a look at it to make sure that we understand dose range, tolerability, that type of thing for each drug. But we're very excited to be able to use this as a tool to test new compounds. So in summary, this mouse seizure model demonstrates characteristics that are consistent with human Dravet syndrome. Animals will have hyperthermia-induced seizures, which is consistent with the way that many patients with Dravet syndrome will present and continue to have, as well as spontaneous seizures. We do have some drugs that work, so we have good positive controls, and we have a number of drugs that don't work. And so we feel this is a good starting point to help to identify new drugs that may be working. And again, I'll tell you that the goal of the ETSP is to help to facilitate that work. And so NIH is funding this work, and we'd like to be able to test more drugs in this paradigm. I want to just point out our team to you. Our PI, Karen Wilcox, many of you may know her, is shown there in the front, standing next to me. Karen is a great leader and a great mentor, and we're very happy to have her continuing to direct this program. Chelsea Pernizzi, she's sort of in the upper left-hand side with the blonde hair. She is responsible for a lot of the work that was done initially characterizing this mouse model. And Jeffrey Mensa, he's on the top row, all the way on the far right. He is continuing to perform some of the hyperthermia-induced seizure testing. And so Jeffrey and Chelsea have been principally involved in the work of this project. We also have a number of senior research analysts and lab specialists that are very talented, very well trained to be able to detect seizures and perform this work. And so I'm very grateful to be part of that. And also I want to thank our NIH funders, Brian Klein, who's the director, Shalini and Yogi, who are scientific program managers. And again, if you have a drug that you're interested in and would like to have tested, or if you know of anyone, please send them to NIH. We'd love to test it. Thank you very much for your attention. Questions?
So great talk. Can you talk about the challenge in the mouse model? Because my understanding is the time of onset with spontaneous seizures in Dravet model, and actually when they start to die, so SUDEP equivalent, is pretty short. So for chronic administration, how much time do you really have in there?
Yeah.
And then I guess the other question I would have is, aside from looking at the seizures, have you guys looked at any of the other effects of any of the newer medicines to say, okay, do we see changes in, independent of seizures, behavior, cognition, locomotor skills, any of the other stuff that families want to know?
Yep. Yeah, thanks for the questions. So the first question is about when drugs might be administered and how that relates to mortality. One of the problems that we have is that the smaller mice are really sensitive, and so we initiate treatment as early as we can, starting about P20 to P25, and that is on the tail end of where they're most susceptible to dying. And so most of our treatment is done in what would be adolescent or adult animals. So we unfortunately haven't found a good way to be able to treat our mice at that younger age. There are ways of doing it, and it's something we're very aware of. But for this particular paradigm, we're really more focused on that older age where the endpoint is a little bit more robust and reproducible. Your second question is about other comorbidities, if I may use that term. We have looked at that in this model. They do have what you may expect, locomotor deficiencies, some other behavioral and cognitive deficits. The general goal of our program is to look at seizures as a primary endpoint. So we haven't looked at that, but this model is amenable to that. But because we're focused on seizures, we haven't looked at those endpoints.
We have another question right here.
Yeah, please.
I have two questions. Anyway, thanks a lot for all the good work you're doing. And there's several research groups around the world focusing on mice model. So do you have any collaboration with them? Because I know that some of them are using AI to identify those seizures in the EEGs. But what I heard from you that your team is using like manual screening. So is there any collaboration behind that?
There is. So we do work with a number of different labs across the country that are using mouse models. With respect to your question about seizure detection, we do have an automated seizure detection algorithm that's in development. We do have it for rat, and so it's a little bit of a switch from mouse, but we do plan on bringing that on board that will really help our EEG characteristics and be able to be more efficient. With respect to artificial intelligence, we're very interested in that from a practicality standpoint to be able to reduce our video EEG burden. Having said that, the technology is not quite there, but I'm really hopeful that it will be soon.
Okay. Another question.
Yeah.
About different animal models. So what do you think about comparing mouse, zebrafish, or monkey? Which one is more relevant for human?
Yeah, this is a great question, and I'm happy, I guess, to debate anybody that would like to further this. And what you may have heard yesterday is the utility and the importance of zebrafish models. My argument is that they are very complementary. There are tests that can be done in zebrafish that are just not as easy to do in mice. The question before about younger ages, for example. Zebrafish may be a better way to go. The types of therapies, particularly when it comes to therapies focused on the gene, maybe easier to try to validate in zebrafish in some ways, depending on how they're administered, of course. And so I look at them as though they complement one another. With respect to non-human primates, I'm not aware of any models necessarily that mimic Dravet syndrome, as well as zebrafish and mice. But having said that, non-human primates are often used in preclinical development, and so we can gain information there.
Thank you.
I think there's one question back here.
Hi, I was wondering if you've ever tested lorcaserin, because several of us are using it off-label use with tremendous success.
Mm-hmm. So we haven't published on that yet. I can say that we have used it. We are not finished analyzing the data on it yet, so that should be forthcoming. In a general sense, we do try to test as many of the agents that we can get our hands on that are either off-label use or in clinical development. And so I hope to have more information for you on that in the future. Thank you.
Did you ever test sudden temperature changes, or not only hypothermia, like hyperthermia, but hypothermia? Just to compare, you know, with our kids, it's going outside from this hotel, sudden temperature change,
Yep.
jumping into pool, like
Yep.
temperature goes down. Thank you.
So with hyperthermia, the change in temperature we produce is relatively quick, 2 degrees Celsius. It could be more sudden, but we haven't looked at that. Hypothermia is a little bit harder. These animals are already, when we test them, they're sort of isolated, and they tend to be more temperature sensitive, and so their core body temperatures are a little bit lower anyway. We haven't done the experiments where you reduce body temperature and then work with an increased temperature or even a decreased temperature from there. But the animals can get cold pretty easily.
Do we have any other questions? All right. Thank you so much, Dr. Metcalf.